Our next speaker is Dr. Jennifer Taher. She's a clinical biochemist at Toronto. What's really cool is that she's involved in some local and important national studies looking at COVID-19, seroprevalence, and so forth. She's very actively involved in the CCC committees regarding COVID testing. And of note, not related to COVID, because everyone has other things that they do. I really enjoyed reading a couple of her publications, one in clinical biochemistry in 2020 regarding utilization of hormone testing. And I think that's something that we always struggle with. And interestingly, and it's very underreported, is there's really cool case report in JOM. And then JOM does these cool case reports on hyperviscosity syndrome. We always have issues with that. And so again, just to show that there's a breadth of talent and publications in the area. But Jennifer's going to talk to us about some COVID stuff. So Jennifer.
Okay, thank you. Okay, so today I'm going to be talking about implementation of serological and molecular tools to inform COVID-19 patient management. And the name of this study is called the GENCOV study. So these are my disclosures. And as an overview for today's talk, I'll start by introducing what GENCOV is. I'll talk about the study protocol, and then I'll largely focus on the antibody response part of the project, specifically touching on patient surveys that were conducted, the understanding of serology results, analytical methods used, how we return results back to patients, and the impact it has on the patients and the serological findings to date. So what is GENCOV? GENCOV is a COVID-19 prospective research study that spans 8 hospitals in Ontario and includes a multidisciplinary team of 25 co-investigators and collaborators. GENCOV was initiated by myself, a clinical biochemist, and Jordan Lerner Ellis, a molecular geneticist at Mount Sinai Hospital. And the overarching question that we are trying to answer is, why do some patients respond favorably while other patients respond unfavorably to COVID-19? And we think the answer relates to 3 factors: the immune response of the individual, the viral strain they are infected with, and the genetics of the individual. And so this leads us to 4 overarching aims. The first, to identify the characteristics of the antibody and T and B cell receptor response that results in a maintained immune response and better patient outcomes. The second, to determine the impact of genetic differences on COVID-19 infection severity and immune response. Third, to determine the impact of different viral strains on antibody response and patient outcomes. And lastly, we return these results back to the patients, so we evaluate patient-reported outcomes of receiving the host genome, antibody, and viral lineage results. And to address these aims, we recruited clinical and research colleagues to join our team. So as I mentioned, we have 25 co-investigators and collaborators from various hospitals and institutions in Ontario. And this includes people that have expertise in various areas of laboratory medicine, including molecular geneticists, medical microbiology, clinical biochemistry, and various research labs in Ontario. We have physicians and nurses in the emergency department, as well as infectious disease experts. We have physicians and nurses in ICU and medicine, as well as other physicians in other specialties that include neurology as well as genetics. And finally, we have an internal research team that helps drive the project forward, doing consenting, recruiting, sample handling, and data analysis. The goal is to recruit a total of 1,500 adult patients that are PCR positive, and to date, we've recruited almost 700, with a majority being outpatients, but also having a significant portion of inpatients, which are quite hard to obtain. So we mainly recruit from Sinai Health System, William Osler Health System, which is actually our largest inpatient recruitment site, and Mackenzie Health. And we're very excited to be the only study recruiting from the first COVID-19 hospital in Ontario that's located at Mackenzie. And more recently, we are onboarding the University Health Network as well as Women College Hospital. So, to discuss the protocol of GENCOV, as mentioned, the aim is to recruit 1,500 individuals with mild or severe COVID 19, and that's based on whether they're an outpatient or inpatient. And then at the baseline measurement, which primarily is taken in inpatients only, we take a blood sample that's shown in the blue boxes, and that's used for serological testing as well as T and B cell receptor sequencing. So we then receive the viral swab that's shown in the red boxes, and that's for the viral genome sequencing to determine the strain. And lastly, in yellow, we gain access to the patient chart to collect data on labs, symptoms, clinical conditions, medications, patient outcomes, and we also do a patient intake survey to collect information on demographics, clinical history, result preference, and understanding of results. At the 1 month time point, another blood draw is performed for serology and TMB cell work, as well as for host genome sequencing, which only needs to be performed once. And at this point, we start returning the serology results back to the patient. We do not return the genome results back yet. First, the patient watches a decision aid video, which gives them information on the genetic tests that they can receive back, as well as a brief explanation on their serology results interpretation. And then they meet with our genetic counselor to discuss their choice of genetic tests and also their serology results. The genetic tests are then returned at 6 months, where a follow up is booked, and patient outcome measures are assessed, where we hand out surveys to understand the impact of returning these results back to the patients. At 6 months and 12 months, we continue to do 2 more additional blood draws to assess serological and T and B cell receptor response. And you'll notice the Dynacare logo on the slide, and that's because if you do enroll in our study, you can get a blood draw at any Dynacare location in the province, which makes it very convenient for our patients. Now, most recently, we have introduced a new cohort, which is the vaccine cohort, and this is an additional 300 patients that we are aiming to recruit that have not had COVID-19 infection, but have received a Health Canada approved vaccine. And in this cohort, we plan to do only the serological and T and B cell receptor sequencing at 1, 6, and 12 months after their dose. And if it's a double dose vaccine, then we will do a blood draw at 1 month after the first dose and 1, 6, and 12 months after the second dose. This cohort does not receive genetic testing and does not participate in the outcome surveys. Now, because they are the newest addition to our study, I don't have enough data on this cohort to share with you today. So as mentioned, after patients are enrolled in GENCOV, we hand out a patient intake survey to get some general information on our patients. So we've handed out about 542 surveys so far, and we've received 333 responses, which is a 61% response rate. Now, most of the data I'll show you from the surveys is from outpatients, as we didn't have a large enough number of inpatients in our initial recruitment. The response between males and females is approximately equal, and we see that most respondents fall between the ages of 25 and 64 years of age. We ask several questions in the intake survey, and one of those questions is to ask what symptoms they experience while having COVID-19. And we can see here, not surprisingly, that the most common symptoms among the patients are muscle aches, runny nose or nasal congestion, fever, cough, sore throat, joint pain, and fatigue. Interestingly, we only had 4% of individuals indicate that they were asymptomatic, despite the higher numbers that are being reported for asymptomatic individuals. We also ask about underlying conditions, and we have broad categories. And then if they respond yes to a broad category, we go into further details to ask which specific conditions they have. So we see here that the most common conditions in patients that had COVID-19 included patients that were previous smokers, that had hypertension, or had gastrointestinal, respiratory, or cardiac disease. Now, the rate of smokers and hypertension is close to what we would see in the general population. However, the other conditions would need to be broken down into the subcategories before we can comment on whether they are higher or lower prevalence. And keeping in mind that most of this survey data is in outpatients, so would be interesting to see how these numbers may change when we have the inpatient data. In terms of ethnicity, unfortunately, we do have a biased population with more than half of the population being white and European. Although the hospitals we recruit from do have large population diversity, so we were a little bit surprised, and we are hoping to recruit more diverse ethnic backgrounds going forward. In terms of educational background, we ask this question because this variable can impact how they understand and interpret their results. So in our cohort, we have a majority of patients having a bachelor's degree or higher education, and few patients only having a high school or less. We next ask if they are interested in learning their serology results, and we see from the first pie graph that an overwhelming majority respond yes. And we next ask if you are found to have COVID-19 antibodies in your blood, would you tell this information to your family members? And again, the response is yes, with only 10% being unsure and 1% indicating no. We ask similar questions about genetics and we see quite different results. So now that we've asked them if they want their serology results, we hand out a survey first to determine what people know about COVID-19 antibodies before returning their results. I'm going to show data from before result return, but we hand out the same survey closer to the end of the study when they've received 2 to 3 results and after they've had the opportunity to speak to us about what their results mean, and we will assess their change in understanding over time. We ask 9 questions and assess their understanding by asking them to respond on a 5-point scale that ranges from strongly agree, agree, neither disagree nor agree, disagree, and strongly disagree. So the first question is, having COVID-19 antibodies means that I'm protected from getting a COVID-19 infection in the future. And we see that more than 30% agree or strongly agree, and approximately another 30% is unsure. This is really concerning that this is the general belief because we are unsure of how long antibodies remain and how that correlates with immunity over time. The second question is, having a positive COVID-19 swab and not having COVID-19 antibodies means that I'm more susceptible to COVID-19 infection in the future. We expected most people to be unsure, neither agree or disagree, which is what we see, but a large portion also agree to this. So again, perhaps they don't recognize specific factors, including the fact that being tested too early can result in a negative result. However, interestingly, question 3 relates to that point, which is the length of time after COVID-19 infection impacts whether my SARS-CoV-2 antibodies will be detectable. And interesting, mostly people agree, which is great. The fourth is, I may have been asymptomatic carrier if I display no symptoms of COVID-19 infection, but have a positive COVID-19 swab and antibody result. And most patients also agree, which is great, although we may have expected more to strongly agree as well. In question 5, my COVID-19 antibody results should always match the COVID swab results. We have a lot of uncertainty to this question, or some neither disagree nor agree. And then the next question is, not having COVID-19 antibodies means that I never actually had a COVID-19 infection, even if my COVID-19 swab was positive. We see mostly people disagree or strongly disagree, but still a lot of uncertainty here. Question 7, scientists know everything there is to know about how COVID-19 antibodies work. So obviously not, and most people agree with that. Or disagree with the statement. It's interesting to see some people strongly agree with this statement. Nice to see the confidence in scientists, but obviously we don't know everything there is to know. Question 8, serology testing for COVID-19 antibodies is available to everyone who gets tested. We expected most people to disagree here because many people ask for antibody testing and enroll in studies for this reason, but we actually had a lot of uncertainty. Question 9, if my COVID antibody results are positive, I can reduce social distancing measures. Very happy to see 70% disagree or strongly disagree, but we have 30% with indicating neither, and that's pretty alarming because the recommendations on whether or not to reduce social distancing has nothing to do with antibody results. So obviously some clarifications need to be made. We do have many other questions on genetic and viral results, and I threw one question in here to show you the type of questions we have about viral results. So my COVID-19 viral strain result may change if I'm eligible or not to receive the COVID vaccine. So many people are not agreeing or disagreeing. So perhaps, again, some misunderstanding here on what these variables mean and limited resources for patients to get information. So after this baseline survey, we now return the serology results back to them and we counsel them on what the results mean. And then we ask the same questions again at a later time point. Next, I'm going to briefly touch on the analytical methods, quite briefly, that are used in our study. So the COVID-19 virus has 4 structural proteins, but most assays target antibodies against either the spike or the nucleocapsid epitopes. And several of the spike assays specifically target the receptor binding domain, which is needed for the virus to bind to ACE2 on the target cell and allow entry. And antibodies are produced within 10 to 14 days after symptom onset. As we can see here, there's a rise in IgG and IgM, and we would expect IgM to fall over time. So note that IgA is not shown here on the slide because it's commonly not measured in a clinical setting, and most Health Canada approved assays are for IgG or total antibodies. So we use the Health Canada approved Roche assay for total antibodies, which means that it may detect all isotypes, IgM, IgA, IgG. And we use a qualitative assay that targets the nucleocapsid antigen and a quantitative assay that targets the spike antigen. And it's an electrochemiluminescent immunoassay that is a double antigen sandwich. We also use a research ELISA that was developed by Dr. Anne-Claude Gingras at the Lunenfeld Institute in Toronto. And this ELISA will help us to better characterize the antibody response because it differentiates the 3 different isotypes, IgA, M, and G. And it also targets the 3 different antigens, spike, receptor binding domain, and nucleocapsid. And the details of this assay are published in Science Immunology, and the assay was also validated against the National Microbiology Laboratory, the Canadian Blood Services, and the Toronto Invasive Bacterial Network. They've also developed a surrogate neutralization assay, which is a competitive ELISA where antibodies compete with the labeled ACE2 for spike binding. So this is a safe, simple, and scalable for initial screening. Because it's competitive, low signal would suggest higher neutralizing antibodies. And this is also published as well. And we will be utilizing both assays in our study. However, I currently don't have any results for the neutralization assay as of yet. So once we run the serology tests on these assays, we return the results back to the patient. And the results are returned only for the Health Canada approved Roche assay. So we don't report back the isotypes. And so we have 2 results per patient. We have the Roche nucleocapsid result and the Roche spike results. And then we generate 3 reports based on this. If both assays are negative, we report out a negative result. And I've taken a screenshot of part of our report, but the full reports can be found in our protocol paper, which is currently under review. But ultimately, we indicate that a negative result does not mean that you're at higher risk of infection. And it is possible that they were tested too early, because keeping in mind they do have a positive swab. Or perhaps they were tested too late. Also keeping in mind, we are going to be measuring them for or monitoring them for about a year, and antibody levels may decline over time. If only one result is positive, we call it inconclusive, and we indicate that perhaps this may be due to borderline samples, false positive or negative results, as well as the fact that they may only have one type of antibody present. And lastly, if both are positive, we hand out a positive report indicating that this does not necessarily reflect immunity, and we report a quantitative level for the spike antibodies, but indicate we don't know the relevance of it. Now, learning about antibody results is obviously different in the vaccinated cohort. And what I showed you was the reports we hand out to the COVID-19 cohort. I won't show all of the reports for the vaccinated cohort, but I'll briefly mention what we indicate. If the patient has spike-only antibodies, this is the expected response that we would see of all Health Canada approved vaccines. If the patient has nucleocapsid only, we suggest this indicates possible previous infection, and perhaps the sample was collected too early to detect the spike antibody after their vaccine. If both are positive, this is an expected response again because we see the spike, but the nucleocapsid still suggests a previous infection. And if neither are positive, we indicate that this doesn't mean your vaccine wasn't effective. Perhaps it's due to only receiving one dose, or the sample was taken too early. After we return the results back to the patient, we will hand out surveys to assess the impact of those results. And so some of the questions we ask are the following. Because of my COVID antibody results, and we ask them to check all that apply. So did they speak to their family doctor, a medical specialist, a genetic specialist, another type of healthcare provider that they can indicate, a laboratory, did they have any additional laboratory testing performed? Did they make changes to their medications or plans for future, such as financial decisions, or have they taken any other action? So we also ask these questions for receiving genetic results, and we ask them to tailor their response to which result they received. So if they answer yes to speaking to a healthcare provider, we ask why. So is it because they didn't understand their results? They felt it required medical follow-up. They wanted their results placed in medical records. Their healthcare provider referred them for follow-up, or another reason. And lastly, which healthcare provider was able to help them understand their COVID results. Was it a family doctor, a medical specialist that they can specify, somebody else that they can specify, or no healthcare provider was able to help explain, or they did not speak to a healthcare provider about their results? So lastly, we do ask them whether their specific activities or habits have increased, decreased, or stayed the same for social distancing, hand hygiene, diet, exercise, smoking, social activities outside of the home, going outside of the home to the workplace. And that was a big one with antibodies initially, a big question. And then essential activities or non-essential activities outside of the home. And again, we ask these same questions when looking at the genetic results. So the last part of my presentation, I am going to focus on the results from our serology data. So we have separated results out for inpatients at baseline, inpatients at 1 month, and outpatients at 1 month, and determined what percentage of patients are positive, negative, and inconclusive based on the Roche results. And we can see that the majority of inpatients at baseline are positive, 26% are negative, and about 10% inconclusive. And these are all taken within 14 days of being PCR positive. For inpatients at the 1 month time point, we had 100% positive, but a very low N value here. And for outpatients, we have about 94% positive, 2% negative, and 4% inconclusive. We then stratified the data to look at different age bins that were separated out by 18 to 34 years, 35 to 59, and 60 years or greater, based on considerations of younger, middle, and older patients, also relating to risk as well. And then we also stratified by sex, with blue indicating males and pink indicating females. And the y-axis is the quantitative Roche result of the spike antibody. And this data depicts only outpatient data at the 1 month time point. And we can see that for both females and males, there's a significantly higher level of spike antibodies in patients that are 60 years or older, in comparison to the middle and younger age categories. And there's no significance between males and females for any age category. We did the same analysis for inpatients and separated out by baseline on the left and 1 month on the right, but the N values are really too low here to be able to do any statistical analysis. So we now have recruited over 100 inpatients, and so we're waiting on our serology results so that we can assess whether we can see similar trends here in the inpatients. We did do a further analysis on the outpatients to differentiate the isotype, and the blue line represents a linear relationship and the gray is the confidence band. And we can see that there's an increased likelihood of a positive result with as age increases, which was statistically significant for IgA and M, but not for IgG. We can separate the analysis out even further to look at differences with antigen targets shown on the left and isotypes shown across the top. And so when looking at the spike protein, we can see that most commonly patients that had antibodies that targeted spike had IgG antibodies, and this was true across all three patient categories, and the least common isotype was IgM. When looking at receptor binding domain targeted antibodies, we see some different trends here. So in patients at baseline, you have IgG and IgA being the most common. For 1 month, we see relatively equal distribution. And for outpatients, we see an equal presence of IgG and IgM and lower positivity with IgA. And lastly, when looking at nucleocapsid targeted antibodies, we see for inpatients at baseline and 1 month, that IgG and IgA are most common, and for outpatients, we see the highest presence of IgG, and least likely would be the IgM. Now, when comparing inpatient baseline to 1 month values, and we have significance here reported in blue, there is a higher level of IgG and IgM positivity rate in inpatients at the 1 month, specifically for the receptor binding domain targeted antibodies. Now, again, we have very low N values here for the inpatients, so we are cautious to draw any conclusions, but this is our preliminary data for inpatients. And when comparing outpatients and inpatients at 1 month, we do see a higher IgA and IgM positivity in inpatients for spike, and higher IgA for nucleocapsid. So again, obtaining higher N values will help us to confirm. It's important to note that a patient may be positive for more than one type of antibody. And so here we show the number of outpatients where the outpatients that tested positive for IgG mostly had all three antigen targets, so spike, receptor binding domain, and nucleocapsid. In fact, all patients that tested positive for IgG had the spike protein, whether it was alongside receptor binding domain and nucleocapsid or spike alone. When looking at IgA positive patients, significantly less had all three antigen targets. And we see again that all patients except for one had the presence of the spike protein targeted antibodies, with only one having antibody that targeted nucleocapsid alone. And more commonly, we see there's only two antigens targeted, it tends to be the spike and the receptor binding domain. So lastly, when looking at IgM positive patients, we see even less have the 3 antigen targets, and most commonly only the spike and receptor binding domain are targeted, and more patients in this case showing only 1 antigen target. And for IgM, this was a receptor binding domain only. So we do have a series of other projects ongoing that are related to looking at the antibody response. So we are looking at how different clinical correlates relate to antibody response, such as BMI. We do have a method comparison with Dr. Anne-Claude Gingras on the research ELISA. Dr. Pugh is going to be looking at the relationship of antibodies and T and B cell sequencing. Dr. Simpson is going to be looking at the relationship with antibodies and viral strain. Dr. Lerner Ellis, the relationship with genetic variability, and Dr. Bombard, the impact of the result return. And so they're truly the experts on all those other categories. So in summary, I hope that I was able to show you that GENCOV is a community of laboratory and clinical investigators that aim to answer important questions to improve COVID-19 patient management. The project covers aspects of the immune response, viral strain, and host genome sequencing. Patients can receive their results back, and the impact of the results are assessed. Data is collected through patient surveys, lab testing, chart review, and result return. And I showed you some data on the total SARS-CoV-2 antibodies targeting the spike protein in outpatients that increases with age. And most patients are positive for the IgG, which most commonly targets the spike protein. So if you are interested in joining our team, either as a co-investigator, if you have interesting questions, you want to work with our data, or you're interested in being a participant, you can contact us at gen.cov@sinaihealth.ca, or you can follow us on Twitter at GenCov Study to see what we're up to. Or if you want to hear more on the data that we have to date, as I wasn't able to show too much today in half an hour, then I encourage you to attend our symposia at the AACC CSCC on September 28th. We are having 3 speakers from GENCOV talk a little bit more on the data of the serology findings, the genetic data that will be by Jordan, and then the T and B cell receptor signaling or immune repertoire diversity. And so with that, I'd like to thank the entire GENCOV team and happy to take any questions.
Well, great talk, Jennifer. Thanks so much for that. You know, and so it goes to show you, if you have a great speaker, you can make up for a bad moderator. We're right on time. So we're just going to go a little bit over on in the coffee break or whatever break you want. So the first question I have for you, and it's obviously great to see Canadian data. It's really, really important because it puts it all in perspective, especially you know, what we're dealing with. So congratulations on, that's a comment, congratulations on funding and doing this, which is amazing. The first question is that what is the basic importance of neutralizing antibodies versus other antibodies? And how are you translating that? I'm adding that part. How are you translating that to patients? Because I'm sure that's what they'd like to know.
Yeah, so we've tried to keep it super simple with our patients and only releasing back the Roche results, sort of telling them you're positive, you're negative. We don't get into releasing back whether they have neutralizing antibodies or what isotypes. We chose not to take that approach. So we don't tell patients if they would have neutralizing antibodies or not. But part of the importance in knowing neutralizing antibodies is that they can provide potential immunity. So immunity is linked to the presence of neutralizing antibodies, and not all antibodies are neutralizing. Now, keeping in mind that you can still have immunity without having neutralizing antibodies. So there's still antibody immune enhancement through different mechanisms, but that is one mechanism that can indicate immunity. And so that's why we're interested in looking at it.
Another question I have for you, and I think the thing that's really nice to see is that you're actually doing the surveys. And I don't know if there's going to be some more social or some more feelings or other types of aspects on mental health that you're probing in there. But one of the challenges when you do surveys is the non-response. I mean, 60% is pretty good, but have you drilled down to see what's happened with the other 40% that's not responding to your surveys?
Yeah, so I mean, this is our initial survey that we had sent out. And so we initially sent out about just over 500. Now our cohort is closer to 700. And we do follow up with these patients at the 6-month time point, which is when they're going to meet with our genetic counselor. And at that point, we will remind them, can you please fill out the survey and then have your meeting with the genetic counselor? So sort of to try and catch them at a later time point to fill out that survey, still before they haven't received their results back. So we think that we can catch them, but perhaps initially they haven't filled it out yet. And especially for the inpatients that are just released from the hospital, they don't really want to be filling out a survey, and we have to give them more time.
And that just is going to follow up with my last question. And so your inpatient data, I know you say you have 100 now, but it was 84 and it dropped to 22 at 1 month. Hopefully it wasn't 62 patients that died. How many of them died? How many of them, just were lost to follow-up? Or can you give me a little bit of breakdown on what happened to those 62 patients?
So unfortunately, we do have a very large number of deceased patients in our cohort. We do. I think we have more than 50 deceased patients in our cohort.
Oh,
So these patients won't be monitored over time, but their baseline data is quite important to us. And when we have more numbers, we will separate them out to understand, particularly with their genetics, was there variability in their genetics that made them more susceptible? However, we also have some inpatients that we don't catch at the baseline because by the time that they're admitted, they have been staying at home and were sick for so long that it's past the 14 days, and we only consider 14 days a baseline. So some inpatients we don't have baseline, and some baseline inpatients we won't be able to get further time points.
yeah, it would also appear then though that mortality rate well over 50%. That's a little. I know it's high. It's about 20% or a little bit lower, but that seems to be a little bit high. So are you thinking you're just capturing the really really sick patients, or do you know?
I think it's based on our recruitment strategy. So we were able to keep samples for deceased patients in the laboratory. Um, you know, um, for a period of time, like over a longer period of time as our project was progressing. Whereas with the inpatient recruitment, for the longer time points, that was harder to obtain. So I think it's related to our recruitment strategy.
Perfect. Okay, well, with that, I'm going to thank you again for a fantastic talk on some really cool Canadian data that's coming out, and looking forward to seeing more of that data as well.